Great. Hello, everybody. Going to give you all just a minute to get connected. Still seeing a lot of people entering from the waiting room, connecting to their audio and to their video. I love seeing all your faces. So thanks to all of you who have your videos turned on and are willing to show your smiling faces. It's so good to see you and at least try to stay connected virtually. My name is Anissa Mitchell. I'm with PMD Alliance, and I am so happy to see all of you today and welcome you to our spotlight today. We're going to be talking about a peek inside of your brain, what is going on with the brain with Parkinson's. We have an expert in the brain that is going to be sharing what is happening. And before we get started, just wanted to invite you all to hover over here at the bottom of your screen and pop that chat box open, because that is where we'd like to get your questions. So feel free to ask your questions throughout the program. I think we're going to wait until the end just so that we can get through the presentation. We will have some slides and we will make those available after the program, but then we'll kind of go back and go to those questions. And yes, give us a shout out and let us know where you're joining us from. I love to see where all of our folks are coming from. We've got people in Pennsylvania, Dave, so let us know. We've got Vancouver, British Columbia, great to see Canadians represented. So yes, give us a shout out. So I am going to introduce our speaker today and then let him get started. So with us today is Dr. Anthony LoGalbo. He is a board certified clinical neuropsychologist, and I think he'll spend a moment explaining what a neuropsychologist is in relation to psychologists and what the difference is. He serves as an associate professor at Florida Tech in Melbourne, Florida. He specializes in the assessment and treatment of patients that have had traumatic brain injuries and concussions, people who have had other memory disorders, neurodegenerative disorders, does very involved neuropsychological evaluations, and he's going to explain what those involve, how those can be beneficial to you, and what they tell you. So I'm happy to have Dr. LoGalbo. We've worked together through the years. I'm also in Florida. He used to work at the same place I did prior to coming to PMD Alliance. So we've actually had opportunities to work before, and I've heard him speak before. He's really good. So good to have you, Dr. LoGalbo.
Thank you, Anissa. I appreciate it. And thank you for inviting me to speak to your group. I'm excited to have an opportunity to chat with such a wide audience here. It looks like, wow, we're over 150. That's quite a large number, and from all over the place, which is really cool too. I think I saw Australia pop up in there even. So international conversation we're having here today, which is very exciting. I'm gonna try to share my screen here. It looks like I'm able to do that. And hopefully now you're just seeing the slides here and not all of the other PowerPoint information. But if at any point this starts to look kind of funny or incorrect, just let me know and I'll try to fix it here on my end. As Anissa said, I'm a neuropsychologist, and maybe some of you have heard of a neuropsychologist before. Many folks that I encounter have not. So I will explain a little bit about what that means. And as Anissa mentioned too, I have experience in clinical practice in a hospital setting, but I'm also currently a professor as well. So I'm teaching graduate students and doing clinical supervision. One of my main responsibilities is at a memory disorder clinic, where we primarily see folks who have concerns about their memory and perhaps have Alzheimer's disease. But occasionally we also see individuals with Parkinson's disease or other types of neurodegenerative diseases as well. So again, I'm real excited to talk with you guys about this. Some of what I'm going to cover may be a little familiar to you, but hopefully I have some new information to share with you today as well. So first, I want to talk a little bit about what is a neuropsychologist. It's different than a regular psychologist because we specialize in working with people that have neurological conditions rather than mental health or psychiatric conditions, which I think usually when people think of a psychologist, you might think of someone who works with a person who has depression or anxiety or something along those lines, where most of my patients, they actually have something neurological. There's an issue related to their brain and how their brain is functioning. And so the main thing that a neuropsychologist does or is interested in is examining the relationship between what's going on up here in the brain and how someone is behaving in their life. And in particular, I'm interested in our thinking abilities, things like our ability to learn and remember information, our ability to focus and concentrate or pay attention to things. And also, of course, I am a psychologist, so I'm also interested in our mood. If people are experiencing some difficulties with feeling sad or nervous, sometimes irritable, because of some changes that have taken place in the brain. As you might know or imagine, our brain is very complex. It's responsible for nearly everything about us and everything that we do. And so if there's some changes going on in our brain, it can potentially affect a lot of things, from our motor skills to our thinking abilities, our language abilities and speech, our mood and our emotions. So all of those things come into play and potentially are of interest to someone like myself, a neuropsychologist. So a few things you may already be familiar with, but just to kind of make sure we're on the same page here, one of the critical areas in the brain as it pertains to Parkinson's disease is an area called the substantia nigra. And the substantia nigra, as you can see in this image here, it's almost right in the center of your head, if you kind of can imagine where that is. And usually the substantia nigra has these dark pigmented areas like on the top right portion of the screen here. However, with Parkinson's disease, those dark pigmented areas are diminished. And really what that is dopaminergic neurons, neurons that primarily work with dopamine, which is a neurotransmitter in the brain. And when those neurons are depleted, it causes this diminished appearance of the substantia nigra in that area of the midbrain, sort of right in the center of our head. I believe, and some of you may have heard this statistic too, I believe they say that 70% of the neurons in the substantia nigra are depleted before someone shows signs of Parkinson's disease. So your brain is pretty resilient, I often like to say. It can withstand quite a bit, but 70% of those neurons, once those are gone, that's when the brain can't really overcome that. And some of these motor symptoms in particular are more likely to appear as a result of this change in the substantia nigra. Here's an example of what the brain tissue in the substantia nigra should look like on the left, and what it actually looks like perhaps in someone that has Parkinson's disease. And these dark sort of blobs on the left, this is under a microscope, looking at a tissue sample. We can see a whole bunch of these neurons in this tissue sample, whereas over on the right, we see far fewer of them. Those neurons are unfortunately gone. And that's one of the things that happens there in that area. Another term that some of you may have heard is Lewy body. And one way that I like to describe this is to compare it to something that's a bit more well known to most people, and that's Alzheimer's disease. You've perhaps heard that in Alzheimer's disease, there's an accumulation of certain proteins in the brain of someone that has Alzheimer's disease. And usually those proteins are tau, T-A-U, and amyloid. Well, in Parkinson's disease, there's an accumulation of proteins as well, but this protein is called alpha-synuclein, which is down here written on the bottom of this slide, alpha-synuclein. And when that protein accumulates to an abnormal degree inside someone's brain, it forms these things called Lewy bodies. Now, why is it called Lewy body? Well, another thing that I often like to say in medicine, we aren't very creative with how we come up with names for things. Lewy body is named after this guy here over on the left, Dr. Lewy, that was his name, and he discovered this. So of course it got named after him, but that's what a Lewy body is. It was named after the person who discovered it. But these are things that, again, are very common in Parkinson's disease. If anyone were to have an autopsy on their brain and we're looking under the microscope, this would be something that we would see. You cannot see these when someone is still alive. They don't show up on an MRI or a CAT scan. So we don't know for sure that they're present until someone passes away and we do an autopsy, but we suspect that those are there if someone has the physical and clinical symptoms of Parkinson's disease. So something else that you've probably heard or familiar with, and I mentioned a moment ago, dopamine. Dopamine is a neurotransmitter in the brain, and it's the main neurotransmitter in the brain that's affected among folks that have Parkinson's disease. Normally, if dopamine is present in someone's brain, it allows a variety of things, one of which is the ability to move or stop moving as we want to with control. As you can see in this lower picture here, there's far less dopamine floating around between these neurons. And with that deficit in dopamine, it impairs our ability to control our movement. And this picture on the right, we can see this guy's head and brain kind of shows the area of the brain specifically where this is problematic. It's kind of tiny, but there's a little red arrow in there, and that's showing kind of the pathway from the substantia nigra that we looked at a moment ago to some other areas, subcortical areas in the brain, where dopamine normally would flow. It would pass along through these neurons. But when that's disrupted because of that depletion of those dopaminergic neurons in the substantia nigra, it causes some of these symptoms listed here: tremors, slow movement, rigidity, some of the other motor symptoms that are involved with Parkinson's.
Dr. LoGalbo, I know
Yes.
I said I was going to hold questions, but I do have one that I think that would be helpful just
Sure.
as you're discussing the loss of dopamine. And there was a question of, is this the same in people who have MSA or any of the other atypicals, like PSP, MSA, Lewy body?
Sure. Yeah, that's a good question. I think I don't know the answer off the top of my head, to be honest with you. However, I would say this: the pathology of some of these other conditions can be a little bit different. And even though there are conditions that are referred to as Parkinson's plus conditions, which might be some things like progressive supranuclear palsy and corticobasal degeneration, things like that. The reason why they're considered Parkinson's plus, it's not really because the pathology is similar to Parkinson's, it's because the clinical presentation looks similar to Parkinson's, but the underlying neuropathology, what's going on in the brain, is a bit different. But as far as the degree to which dopamine may be involved, I don't recall off the top of my head. It seems like it's likely, because those other conditions do involve motor symptoms, although the motor symptoms may be slightly different than what we see in the typical Parkinson's presentation. But actually, now I'm kind of curious, and maybe it's something I need to go back and look at and remind myself of. It's a very good question. And yeah, that's fine. If there are questions, Anissa, that pertain specifically to what I'm talking about, sometimes it is better to go ahead and address them rather than wait till the end. So I don't mind if you interrupt me.
Okay, we'll do.
This is kind of a complex picture, I know, with a lot of stuff going on, but the main point that I'm trying to make here is that even though, again, usually in the context of Parkinson's disease, when we're thinking about dopamine and where in the brain is the problem, we're usually thinking about this green kind of pathway here in the middle, which is technically called the nigrostriatal pathway, because that's what's involved in the motor symptoms. However, what I'm trying to show here, with particularly with this blue line and all these blue arrows, is that dopamine isn't just in that one little area of our brain. Dopamine goes all throughout our brain. And so when there's a disruption of dopamine, usually it's not just in that one area. It can occur anywhere where all of these areas where all these arrows are pointing. And so in particular, again, from a neuropsychological standpoint, up here at the top, top right, you see it says mesocortical. These blue pathways are more important for things like our thinking abilities, memory, attention, and emotional regulation. So yeah, these green arrows down here, sort of in the middle, that's where the dopamine deficit causes motor symptoms. But if dopamine is a problem in the brain, it's not limited to motor symptoms. Unfortunately, there's a number of other areas that can be affected by this dopamine issue.
And we just had a question. I'm going to interrupt you since you said
Sure.
it good. Sorry. Just to clarify, and I think it is a good question. The person wanted to know, is the problem creating the dopamine, receiving the dopamine, or both? So creating in the neurons, or is it an issue of the receptors?
It's creating, there's less dopamine available. Yeah, but that is a good question. And if I just go back, maybe I can go back here, to this picture here. There are some conditions where there's enough dopamine being released, like in this top left picture, but it's not binding to the receptors very well on the adjacent neuron. But that's not the case here. Here, the case is that there's less dopamine available, less dopamine being produced. Now, some of the treatment, the targets of the treatment might be to find ways of increasing the level of dopamine, maybe replacing the dopamine, or there could still be some avenue of trying to, I think this gets a little more complicated, but prevent the existing dopamine from being reabsorbed as quickly. Any or all of those strategies might be considered because all of them kind of have a similar result, which is just more dopamine being available. There's many ways to try to accomplish that. I wouldn't say any of them are perfect, unfortunately. But if the goal is to try to get as much dopamine as we can to a degree, I mean, we want it to get back to a normal state. There can also be too much, perhaps. But generally, that's not too much of an issue here. There can be multiple strategies to try to increase the amount of dopamine. We will talk about, though, and some of you may know or even have experienced this, that sometimes there can be problems associated with increasing dopamine in some of these areas. It can cause certain side effects. There are some side effects that are common with some of the dopamine replacement medications. Yeah, we'll get to that as well. I'll talk about that some in a little bit. Hopefully that kind of answers the question. So yes, okay, I think I was done here, and we were gonna just look at this briefly. It's very difficult to predict the future, but often this is something I get asked to do. These images try to show potentially what the progression of Parkinson's disease might be in terms of how does it progress within the brain. And so you can see again here over on the left side of this image, it's really kind of isolated to that area, substantia nigra, sort of in the center of our brain. And even as it continues on over time, for the most part, it kind of stays fairly localized, although eventually it will kind of spread out potentially to other areas as well. This introduces then this other term that I want to talk about, which is dementia. Not everybody who has Parkinson's disease develops dementia, but some people do. And again, it's very difficult to predict who will and who won't, but it is a condition of concern potentially, and something that's worth monitoring. So just to make sure we're kind of on the same page about what dementia means, I think it's kind of a confusing word and gets misused sometimes. So I'll describe to you how I use that word and what I mean by it. Generally, when I use the word dementia, I'm talking about something that is a progressive neurodegenerative disease. So it progressively gets worse as time goes on. And I like to use this sort of graph here to show what I mean by that. So on the left side of this graph, we have our cognition, our thinking abilities. And on the bottom, we have age, or it might also be time as time goes on. And usually, we're at some level of cognitive functioning. Maybe not everyone is exactly in the same place for most of their life, but we're all kind of trucking along. Things are pretty stable throughout most of our life. But as time goes on, or as we get older, sometimes our memory starts to slip a little bit. Now, to some degree, that might be normal age-related changes. But at some point, if those difficulties with our thinking abilities become so severe, they cross this line, this threshold, and down here is where we would say, oh, now I'm concerned that this person has dementia. You don't just wake up one day and have dementia. It doesn't happen out of the blue. It's usually a very slow, progressive thing that sometimes takes a few years to develop. Now, interestingly enough, there are also some people who experience a little bit of a decline in their thinking abilities as they get older. However, they don't ever cross that threshold and develop dementia. They kind of plateau here. And they're not the same that they used to be, but they also never really get down into this realm of dementia. And again, it's very difficult to predict who's going to be on which of these trajectories. It's a difficult thing to do, but that's often one of the things that I'm asked to do, and something that a neuropsychological evaluation can be very helpful in trying to determine. So what I want to talk about next, and really for most of the rest of our discussion today, are some of the symptoms associated with Parkinson's, primarily these last two here, the cognitive symptoms and the mood or behavioral symptoms that sometimes come up. I'm sure you've had other folks present on some of the physical or motor issues. I want to focus more on some of these other types of things that can happen. So the cognitive symptoms, for example, these are very different than what we usually see among people who have Alzheimer's disease. Some of you may know or have heard that one of the main problems that someone with Alzheimer's disease tends to have is a memory problem. They forget things really, really fast, sometimes within a few minutes. They don't remember what they had for breakfast or if they had a conversation with somebody yesterday. Usually that is not the main type of issue that someone with Parkinson's disease might have. Sometimes they can have problems with memory too, but it's usually not the main thing or the most problematic issue that we see in people that have Parkinson's. Instead, oops, I went too fast. We see more visual spatial kinds of problems. And so, for example, over here on the right, this is something that some of you may have seen. It's a common brief test that a neurologist might give. They'll show you a picture of a cube and they'll ask you to draw a copy of it. Another one is they might show you a picture of a clock or just ask you to draw a picture of a clock. And what they're looking for is this visual spatial kind of issue, whether someone's having trouble perceiving things correctly. And this is not due to an eyeball problem. It's due to a brain-related issue. After the information from our environment goes into our eyes, our brain has to process and interpret that information. And so someone's vision might be okay with glasses. That's not the issue. The issue is how our brain is interpreting that visual information. And that's something that's more common in people that have Parkinson's. Also, having slower thought process, slower mental processing speed. Maybe I can still do things and think through things okay. It just takes me longer to think through them. Takes me longer to complete certain tasks. People might have trouble focusing or concentrating and paying attention. Maybe it's okay for a few minutes, maybe 5 or 10 minutes, but trying to focus and concentrate for a longer period of time, people may find that they get distracted. It's hard to stay focused and concentrate. And then difficulties with something that we sometimes refer to as executive functioning. And this is a complex sort of mental ability that involves a lot of different things, such as planning, organizing, multitasking, or switching back and forth between two different tasks, making decisions about things, problem solving. These are sort of higher level thought processes that can sometimes be affected, unfortunately, in people that have Parkinson's and some other conditions as well. I just wanted to spend a few extra moments talking about this in particular, because I do think this is a common one, not just from a physical standpoint. Of course, physically, it may take people longer to do things because of some of the motor problems that people can have. But it also can take longer just from a mental or a thought process standpoint. And obviously, this can cause, as some of you may know, a lot of frustration. This is not a fun experience to have and can create a lot of frustration sometimes. The way I think about this often is that there's a balance between speed and accuracy. There are some things that maybe it's really important not to make any mistakes. Like if I'm doing my taxes, I don't want to make any errors there. So if I got to slow down and take twice as long, that's probably better than rushing through it and making errors. But there could be some other things that accuracy is less important. And maybe, I need to get it done quickly. And if there's a few little errors or mistakes here or there, that's not such a big deal. Occasionally, it may make sense to ask someone else to do it for me, because maybe they'd be able to do it faster. However, for a lot of us, we like to do things ourselves. It gives us a sense of accomplishment. We want to feel independent. And even if it might take us longer to do something, even if it might be easier to have someone else do it for us, we still like to have the gratification of doing it ourselves. So these are some challenges to balance sometimes on a day-to-day basis. And it may even fluctuate. Some days we may feel a little better and like we're sharper and we're moving along a little faster. And other days we might not feel that way. It can change. But these are just some of the variables that I try to keep in mind in trying to navigate, okay, how do I try to help someone when they're experiencing these kinds of frustrations? Are there things that might be helpful to consider? I also found this recently, and I thought it was kind of interesting. I'm not trying to suggest here that these are the best steps to making an effective decision. It's just something that I found and wanted to use it as an example. There's a variety of these out there. People write books on how to make correct decisions in life and in business and all kinds of settings. But what I wanted to point out here with this is that there's many steps, whether it's 5 or 8 or 7, whatever it is, there's many steps involved in making decisions. And there's a few steps in particular that if I'm having some struggle with my thinking abilities, it could cause a problem with some of these decision-making steps. As an example, if I've identified what the problem or the decision is, I need to gather information to help me make a decision. And if I'm having trouble focusing or paying attention, I might miss some information that's really important. When I'm trying to identify alternative solutions, maybe I'm trying to make a choice and there's 2, 3, 4 different options, I might miss an important option that I might normally be able to identify, but if I'm having trouble thinking through this process, I might not see an example or an option that's really important. I might have trouble weighing the evidence, the pros and cons of making the decision. I might not see all of the pros or all of the cons. I might not be aware of what some of the risks might be. And then when I choose which decision is best, I might, again, make a mistake if I haven't gathered the right information, if I haven't identified all of the right options, if I haven't weighed the evidence effectively. And so what this can lead to, unfortunately, is an error, a problem with making a decision. And honestly, could this happen to anybody? Absolutely, it could. whether we have Parkinson's or not, whether we have some other condition or not. And that's why one of the things that I do, and maybe a lot of you do already, is if have to make an important decision in particular, I usually am going to talk to somebody that I trust about it and get some feedback to make sure that I'm not missing anything, to make sure that I'm thinking through everything correctly and that I'm weighing all of the pros and cons. And this is something that I encourage a lot of my patients to do, especially if they're experiencing some challenges with their thinking abilities or decision-making process. But again, a lot of people do this anyway. You know, they don't make important decisions without talking about it with somebody else. I think in general, that's a pretty good rule of thumb to have.
Can I ask a question?
Yeah, sure, please.
Because I know that we all believe that we can multitask. So can you just spend a second and explain the difference between dual tasking versus multitasking and how that's affected?
I can try, sure. So I don't know if this is what you're getting at exactly, Anissa, but here's kind of how I think about it. Human beings generally are not capable of literally multitasking. Usually when we think of multitasking, we're not literally doing two things simultaneously. Maybe sometimes, but usually that's not what it is. Usually what I'm doing is I'm focused on one thing and then I switch over and I'm doing something else and then I switch back. You're kind of switching back and forth between doing two things. If I'm cooking and doing laundry, usually I'm not literally like having my hand on a spatula in a pan while I'm folding clothes with my other hand. I'm not literally doing both at the same time, but I might think of myself as multitasking because I'm both doing laundry and cooking, but I'm kind of switching between them. So as it turns out, even though a lot of us try to do that, and we might think that we are more efficient when we do that, the reality is that most of us probably would get things done faster if we just did one thing at a time. If I sit down and focus on doing the laundry and folding all of these clothes, and then I finish that, and then I go and make dinner, it might actually be a little faster. Now, if the laundry's in the laundry machine and it's just on in the background and I don't have to do anything, okay, that's different. But if there's something you actually have to physically be spending your time doing, usually it's better to do one thing at a time.
And I know, I'm sorry.
For everybody.
Going to say that I think that what they're wanting to like hone in is this is perfect because I think we're all need to hear this. And I know that this is something that care partners often try to navigate is getting their loved one to not chew and talk at the same time, or, you know, trying to do those kind of activities where, you know, they really need to focus on, especially if there are some changes in their swallowing or just their, you know, ability to chew and, you know, effectively, just staying on one task versus trying to dual task or multitask.
Yeah, and I'm glad you know that's a good example that may be a little more specific to some folks. If you're trying to do two things that involve the same body part, essentially, yeah. If I'm trying to chew and have a conversation at the same time, again, even for someone that doesn't have Parkinson's, that's probably a struggle. But when there's also a risk perhaps of choking, we're trying to maximize the ability to communicate effectively and make sure that we're understanding each other. So doing two things at the same time that interfere with some of those things or that place us at risk of having a problem, that's even worse. You know, potentially. So Yeah, I think generally doing one thing at a time is not a bad thing. I don't know why it seems like in society that's kind of frowned upon, and the ability to multitask seems to be desirable. Um, but again, my argument would be that most people, when they think they're multitasking, they're really not doing that. And if they are trying to do that, usually it's not as effective as they might think it is. It's often better to focus on one thing at a time. And especially if we want to be accurate. If we're trying to be accurate, if we're trying to be safe, if we're trying to do something that gives us a little bit of trouble, once we make it more complex by trying to do more than one thing, or bounce between a couple of things at the same time, that we're more vulnerable to making mistakes. Okay, so just briefly, I wanted to mention what a neuropsychological evaluation is, or what it entails. Some of you perhaps have had this done. It's nothing invasive. There's no medical procedures. We don't do any scans or anything like that. It's all paper and pencil or question and answer kinds of tests that evaluates different aspects of someone's thinking abilities, memory, attention, executive functioning, which I mentioned a moment ago, language and visual spatial skills, things along those lines. And this is certainly something that I do. I know that you guys are kind of spread around, and I'm sure, though, that there are neuropsychologists in your area. If you want a neuropsych eval and are having trouble finding one, your neurologist probably would be able to find one for you. Or I'm not sure if that's something we can do. I have resources to track down neuropsychologists in different parts of the US and different parts of the world as well. So, but we are spread around as well, and usually not too hard to locate. But the neurologist often will have someone that they can refer to if that's something that anybody might be interested in. So I want to switch slightly from cognitive and talk a bit more about mood for a moment. Now, some people maybe have some of the difficulties that I'm going to be talking about here. Maybe they've had them their whole life. Maybe it's not something new. But other people maybe have never had problems with depression or anxiety. And then after being diagnosed with something like Parkinson's disease, they might show some of these symptoms. And one thing that I stress to a lot of people is that depression can manifest in a lot of different ways. I think we kind of have this idea sometimes in our head, maybe from the TV or a movie, about what depression usually looks like. Someone who's crying all the time and wants to stay in bed and isn't doing much, and maybe even wants to hurt themselves. Well, that is one type of depression, but there are other types of depression that don't really involve those symptoms. It might be more of irritability, getting upset more easily by things that don't normally upset me, or it takes me a lot longer to calm down once I get upset. For some people, it might be more indifference or apathy, like I just don't care about anything. Nothing excites me, nothing is interesting. Even hobbies that I really used to love and enjoy, now I could care less. They're just not that interesting to me at all. Sometimes depression looks like that. So it can look like a lot of different things, and it's important to be aware of that so that we can try to identify if they're happening to us or someone that we love and care about. And some other symptoms that aren't really mood related necessarily, but can sometimes show up with individuals who have Parkinson's disease. Excessive daytime sleepiness, being very tired throughout the day and taking what I call unintentional naps, kind of dozing off maybe in front of the TV, not trying to take a nap, but it happens anyway. And sometimes that's also described as fluctuating levels of attention or arousal throughout the day. This is a little creepy, but maybe in time for Halloween here that just passed, I use this to kind of illustrate how sneaky depression can be sometimes. It can start just like this little thought or idea that pops up once in a while, like this little creature on this woman's shoulder. And gradually, if she's not paying much attention to it, it can get bigger and bigger. And it's enjoying some popcorn with her at the movie theater. And then as time goes on, it becomes larger and larger and kind of gets out of control. And this is one of the reasons why I think it's important to try to identify some of these symptoms of depression as early as possible. If we can catch it earlier, we can do something about it and try to prevent it from getting this bad. But if we don't do anything about it, sometimes it can grow and grow and grow, and at some point becomes so cumbersome that it can be really challenging to get under control. Not sure if you guys have heard this, but this is part of the reason why I'm emphasizing it so much. Depression is the most common non-motor symptom in Parkinson's disease. There's even been some people who have sort of considered Parkinson's disease to be a mood disorder because of how common this is. 60% of people with Parkinson's can experience depression at some point during their diagnosis. And sometimes depression might be one of the first symptoms, even before some of the motor symptoms. Depression can be a first sign that something is different. And unfortunately, it often goes unrecognized and untreated. There can be so much of a focus on other things that mood gets overlooked and not addressed. And that's, again, part of the reason why I'm emphasizing this so much today. It does seem like there's probably a neurological basis for this, and it's probably related to dopamine. Neurotransmitters in our brain, one of the things they do is regulate our emotions. However, for some people, it's also difficult to adjust to some of the changes and limitations that we might encounter because of this physical diagnosis of Parkinson's disease. So it's kind of a double whammy in a sense. The changes in our brain may be contributing or making us more vulnerable to develop depression, but we might also be more vulnerable to experience depression because we have a condition that is affecting us in such a meaningful way. And that's not an easy thing to deal with. That combination of things contributes to why depression is so common. And as I mentioned, depression doesn't always look the same. Some people do feel sad or down and blue. Some people don't really feel that way. They feel, like I described before, like they just don't care about anything. Nothing's that fun or exciting. They're not interested in things that normally they would be interested in. Maybe they're more irritable. Things bother them and they get upset. They have a short fuse. Sometimes they might have less desire to be social or interactive with people. So it can show up a lot of different ways. And if any of these things ring true for you, or you are seeing them in someone else, it's worth mentioning or bringing up to your doctor, because there are things that can be done about it. In particular, this was a study that I came across. It's almost 10 years old now. But they were looking at some medications, antidepressant medications, in folks that have Parkinson's disease. And they found that these two medications in particular, not just that they're helpful, but they were helpful without exacerbating any of the Parkinson's symptoms, motor symptoms in particular, which is always a concern when we're introducing a new medication. We don't want it to make things worse. So point is not necessarily that these two are the only or the best medications out there, but there is some research supporting the use of antidepressant medications in terms of benefiting mood without exacerbating some other issues. But there can also be some side effects, as I mentioned before, associated with certain medications, particularly some of them that increase dopamine in the brain. I kind of alluded to this earlier. But some of those medications, and again, some of you may have experienced some of these side effects or symptoms here, increased sleepiness or drowsiness during the day, some delusions, which basically means thinking, my thinking is sort of distorted. I'm thinking that maybe things are happening, but they're not really happening. Paranoia, I might be thinking that people are stealing from me or trying to get me, or and then the hallucinations. Hallucinations can be sometimes frightening, although often they're not terribly frightening for a number of folks. But those are also things that can sometimes happen because of a medication that might be helpful in some ways, but it can cause some other side effects that are not so desirable. Again, if that happens to you, definitely something you need to tell your doctor and bring to their attention so that they're aware of it. We spent some time talking about depression. I just want to mention a little bit about anxiety too. We all can experience anxiety from time to time, but sometimes there are specific things that come up for people who have Parkinson's disease that are kind of related to that condition as to why they might be concerned or worried. And it often has to do with some of the things I have listed here. Unexpected problems with motor skills, difficulty performing or functioning in a certain way, maybe falling, a fear of falling, a fear of being left alone because something might happen and I may not be able to get help. Or it might be a fear of being around others because I might feel embarrassed by some of the symptoms that I have, and people are able to observe some of those things. Or this last one, I talk with people about this a lot, the impact or burden on their family of caring for someone with this condition. And people might be real concerned. They don't want to burden their family members or their caregivers if they can avoid it. So these are things that might be a little more specific in terms of how anxiety or worry, concern might arise among individuals with Parkinson's. And I like this cartoon here. It says, "You worry too much, it doesn't do any good." And the guy says, "It does for me. 95% of the things I worry about never happen." I don't know if that means it's working, but we often worry about things that never actually take place. Some of us do, at least. So I mentioned a moment ago about hallucinations, and just briefly, I want to come back to that for a moment, because even aside from it potentially being a side effect of a medication, sometimes people with Parkinson's disease can experience hallucinations. As I mentioned before, usually they're not terribly frightening. They can, but they usually are well-formed figures, is the way I describe them. People may be very vivid. I've had some patients describe to me in great detail the articles of clothing that they saw someone wearing sitting in a chair next to them. But often, not always, often though, people also have some insight that it's not real, despite how vivid sometimes they can be. On the other hand, there are also occasions where these can be scary or frightening or disturbing. And so again, this is something that if you are experiencing, it is definitely important to discuss with your doctor about what perhaps can be done to try to help, especially if it's bothersome or frightening and scary. Fortunately, it's not always that way, but sometimes it can be. know we're kind of getting short on time, but let me mention this and then maybe I'll pause for a moment. Another, it's technically a separate condition, but I also kind of think of it as an associated symptom of Parkinson's disease sometimes, is what's called REM sleep behavior disorder. Normally, when we're sleeping at night, our body kind of shuts down and we're still, we're not moving a whole lot. However, people who have this condition, they're often described to be acting out their dreams. And so you can see this gentleman here, he's dreaming about boxing and he looks like he's actually boxing there in bed. And sometimes this can create a problem because the spouse or individual sleeping in bed next to us might get kicked or punched. And this can happen sometimes. And usually the next day when the person wakes up, they have no recollection that this happened. It's not intentional. It's not being done on purpose. But this is another thing that can sometimes occur. And again, something that would be important to mention to your doctor. Of course, if you're the one doing it, you may not know that it's happening, but I'm sure the person sleeping next to you would express some concern and have some issues with that. So let me see where we're at here. Yeah, maybe I should stop here. Anissa, I know that I had some other things I wanted to discuss. If we don't have too many questions, I can try to cover a few other things, but let me pause.
A few, but if
Yeah.
you don't mind, I don't know if you have to rush off. I would like if you could touch on that next slide, the impulse control.
Oh, okay.
And then I'll come back because we do have questions, but I think that would be an important thing to cover real quick.
Sure. Okay. And I do have a little time, so I can hang out for a few extra minutes as well if we need to do that. So yeah, impulse control issues can also come up, and this has to do with the dopaminergic system in our brain. Sometimes it's also referred to as the reward system in our brain. And because of how that reward system works, if it's out of whack, if it's not functioning as it normally should, it can create a situation where people might engage in more impulsive behaviors, meaning they're not able to control themselves, doing things that sometimes can be problematic or even risky. And some examples, not just pushing a button like here, but some examples of this sometimes include gambling. Sometimes it's behaviors that are sexual in nature. Trying to think of some other examples of this that can come up. Anissa, if you think of any, let me know. But those are the couple that come to my mind.
Too many Amazon packages.
Oh, shopping. Yes, yes. Shopping and purchasing things. Sometimes eating can be one. Overeating. I mean, basically, it's like something occurs to us to do, and then we can't stop ourselves from continuing to do it. Sometimes, even if we know that it's not right, some people may not have much insight to know that it's right or wrong, but occasionally, even if I do know that I shouldn't do it, I can't stop myself from doing it anyway. And yeah, if it's things of a financial nature, like purchasing things or gambling, this can create a lot of financial heartache for people and get people into real problematic situations. So again, this is something that sometimes happens among people that have Parkinson's disease. It also is something that can happen as a result of the dopamine medications. And it doesn't happen to everybody, but it is another thing that if you're observing or in yourself or someone else, this would be something definitely to bring to the attention of your doctor, because if it gets out of control, it can really cause a lot of difficulties sometimes for folks.
And a question just came in. So is disinhibiting behavior a part of that?
Yes. Yeah. Disinhibition is definitely a related concept. And that another way I kind of describe this is that um, there's a mechanism in our brain that kind of works like a gate. And when that gate is working, a thought might pop into my head about something I should say or do. But if I realize that it's not appropriate or that it might be offensive to someone, that gate helps me keep it from coming out. I'm able to keep it in check. But if that gate is busted, it's broken, then any thought that pops into my head might come out of my mouth, or I might behave a certain way without being able to control or inhibit that reaction before I realize that it's not appropriate. I might realize it after the fact. I might think afterwards, oh, gee, I should not have said that. That was really embarrassing or really offensive to somebody. But if that gate is broken, I'm not able to process that before it comes out. It just kind of comes out of my mouth. I'm not able to control it. And that is another thing. It can happen to folks for a lot of different reasons, but that is an aspect of this impulse control or disinhibition concept for sure.
And is emotional outburst also maybe a part of that?
It can be, yes. I kind of think of that as difficulty regulating my emotions. And again, it's definitely a related concept, although not everybody who has one of these might have the others. In other words, some people they might be disinhibited in some ways. They might say things that are inappropriate or might be offensive to somebody, but that doesn't necessarily mean that they're going to be gambling their money away. Just because one of these things happens doesn't mean they all do. But yes, again, a lot of us, most people, I would say, if we're experiencing an emotion, we may have a way of trying to conceal it or minimize it, especially depending on the situation that we're in. We might realize it's not appropriate to have an emotional outburst when we're at Publix, in a shopping center. So we're able to kind of keep it contained until we get home. But sometimes people have a harder time controlling those emotions. And again, it could be like an anger outburst, an irritability kind of thing, where it's harder to control that emotional outburst. Other times it might be sadness and tearfulness and getting real upset in terms of feeling tearful more easily. So it can happen a lot of different ways, but yes, it is sort of a related concept, controlling emotional reactions.
All right, I have a couple of questions related to the neuropsychological evaluation. So someone wanted to know, do you suggest all newly diagnosed people have a neuropsych to give them kind of a baseline? And then the follow-up question to that is, in relationship to qualifying for deep brain stimulation, why is that a part of that evaluation process?
Sure. So the first question, I don't think it's necessary, but I do like the idea of having a baseline for an individual person. And so, and it seems like in recent years, I've had many more people interested in doing that. What it allows me to do then is, if in a year or 5 years or 10 years or whatever, you feel like there's been a change, a decline in your thinking skills, you can come back and I'll see you again. And now I can compare you to yourself to see how much of a change there has been. Without that baseline, there's other ways that neuropsychologists have of determining where we think someone's baseline should be or should have been, but it's not as precise as having an actual baseline for an individual. So like I said, I don't think it's mandatory, not necessary for everyone when they're newly diagnosed. But if you're interested in having that, I don't think there would be anyone who would, dispute you. I like the idea of having a baseline because to be honest, it just makes my job a little easier down the road. But I think it's also more informative for you if you have that information. As to why a neuropsychological evaluation is done as part of a pre-surgical DBS evaluation, one of the main reasons is to rule out or make sure that someone does not have dementia, because the presence of dementia or more severe cognitive dysfunction is, I believe, usually contraindicated for performing that procedure. There's a higher risk and less likelihood of a good outcome. So generally, I think that's one of the main reasons, to make sure that someone doesn't have something going on that would cause that procedure to be much more risky and less likely to be helpful.
Okay. I don't know if you need to hop off, and I know sometimes people are willing to stay on just because it's such a good conversation. But I did have one, and I know you kind of mentioned this sort of, but I just want to clarify because I'm sure this person isn't the only one that wanted to know. But in your earlier slide, when you showed like maybe some mild cognitive impairment, and then, they might plateau a little bit, but then some of those do go on for dementia. So they wanted to know, like, if someone is diagnosed with mild cognitive impairment, are they more susceptible to dementia? How much more, if so?
So yeah, the answer is yes. Having a diagnosis of mild cognitive impairment does increase the likelihood that it's going to progress. However, when the concept of mild cognitive impairment was first identified, I guess, or conceived, the idea was that pretty much everybody who developed mild cognitive impairment would go on to develop dementia. And what has happened is we've now, over the years, followed many people who have mild cognitive impairment and discovered that there are actually several people who do not progress and develop dementia. And so if you remember that image I showed where some people had a decline, but then kind of leveled off and never crossed that threshold down to dementia, that's what that group represents. They're probably in that mild cognitive impairment category, but they never actually get much worse than that. As I mentioned before, though, I think it's very difficult to predict who is and who is not going to progress. There are some ways to try to predict that a little bit. It's not 100% accurate, but there are some things that I do as a neuropsychologist to try to help predict that to a degree. But it's really, to some degree, it's very difficult to do to predict who's going to progress and who isn't. But there are some people who don't progress, so that is true.
And I think I'll just ask you one more question, and then
Sure.
you have other requirements you have to get to. But when you talked about the neuropsychological evaluation, and whether we do it early and get a baseline or not, if you find some changes in it, can you explain like how those can actually help people to understand what is going on, and then how you as a neuropsychologist might show them what their strengths are and how you utilize those reports for people, just so they can kind of get an understanding?
Sure. Yeah. So as I was mentioning before, when we do a neuropsychological evaluation, we're assessing a lot of different aspects of brain function. And often we are not expecting that someone's going to have trouble in all of those areas. We hope that someone doesn't. We do want to see what areas someone has trouble with, but then if there are areas that are intact, we want to try to use those to someone's advantage and perhaps to counteract the areas that are more problematic. And so being able to see what areas people have trouble with and what areas people do well in helps us to kind of tailor any recommendations that we have for strategies that might be helpful to them. So I can just, I think that was kind of what I was going to get into next. I'll just kind of show these so we're not looking at push the button here anymore. But there's a lot of strategies that I suggest to people to use, some of which may be a little more appropriate for some people or easier for some people than others. But definitely making notes and writing things down, having checklists, using a day planner or a calendar, setting alarms as reminders. This is something that I do all the time. If I didn't have an alarm or something on my phone beeping at me, I wouldn't remember to be here today. Some people prefer a paper calendar though, and that's fine. What you use doesn't matter as much as whether you use something. A pill box. I use a pill box. Some people think, well, gee, aren't you embarrassed? You're not very old and you use a pill box. I don't care about being embarrassed. I want to make sure that I'm doing it correctly. And if I can look in and see, okay, today is Wednesday, did I take my medications or not? That's a real easy way to make sure that I'm doing it right. So there's little strategies like this. Some of you may already use these. If you do, great. If you don't, consider using them. Because I think if you can implement some of these strategies now, even if you're not really having trouble remembering to take your medication, use the strategy anyway, because we don't know what the future holds. And at some point, if it's harder for me to remember whether I took my medicine or not, I'll really benefit from having that pill box to tell me for sure whether I did or I didn't. So these are some of the other things that, again, after a neuropsychological evaluation, when I'm making recommendations to somebody about what might be beneficial to them, given the difficulties they have, I might make some other suggestions like these. Again, just kind of predicting a little bit that for people who have Parkinson's, I mentioned before, it might take longer to do things. Well, how do I deal with that? Allocate more time to get things done. You know, instead of, and if normally, like in the past, it took me a half hour to do something, but now it takes me an hour, maybe that's okay. But that means I need to schedule things way in advance, or I need to start preparing earlier to make sure that I can get it done in that amount of time. We talked about this before, do one thing at a time. Slowing down, especially when having a conversation. We were talking before about chewing gum and talking at the same time. You know, speech and communication can be challenging sometimes, but also really important. And so if trying to do things too fast means that I make more errors, sometimes it is important to slow down and do one thing at a time. And I mentioned before about asking others for advice or their opinions, bouncing ideas off of other people, reducing distractions in our environment. You know, if I'm trying to read, but the TV is on or talk radio is on in the other room, it's going to be harder for anyone really to concentrate and pay attention on what they're reading. So think about things that are in your environment around where you live that might be interfering with your ability to really focus and pay attention and give you the best opportunity to try to concentrate and remember things. And there's some other strategies on here, you know, that some of these that you're doing right now. You know, you're learning new information, you're engaged in a social group for support, even though it's virtual. That still nowadays seems to be the way that a lot of us are functioning, and can sometimes be just as helpful in many ways, just as getting together physically in the same room. So there's a number of other strategies like this that I think we all can really benefit from. Relaxation strategies, recreation, doing things that are fun or enjoyable to us. Some people get involved in creative activities, artistic activities, things like that. That can also be a fun way to try to do things differently or challenge different parts of our brain, and stimulate different parts of our brain, which can always be a good thing, I think, again, for all of us, really.
All right. Well, this has been a fantastic, we could probably go on and on. There's so many different things. So I appreciate you staying on a little extra and
Certainly.
allowing us to gain from your knowledge. And I unshared your screen so that we can see you again, because one of the things that we do when we want to show our appreciation for our fantastic speakers is everybody to be able to see you. You see them as they do the wave of appreciation to you. So we do appreciate you. Before you all go, if you want to save your chat, I know some of you like to save it. If you go down to the bottom where you would write your questions, there's 3 little dots at the far right. If you click that, a little box will pop up and it gives you the option to save your chat. Sometimes they want that so they can remember the links that we put in there. This is recorded. It will be available on our archive, so you can go back and listen to it because it was full of information. And so you might want to go back and review it. And we do thank you, Dr. LoGalbo, for joining us, for sharing all of this and answering some of our questions today.
Absolutely. Yes, it was my pleasure. Thank you all for your attention. And I know it's a lot of information to absorb. I hope it was helpful to you, and I look forward to another opportunity to speak with you again.
Absolutely. All right. Well, here's your wave of gratitude, because we appreciate you. And I appreciate everyone that joined in today for this conversation. We will see you again very soon. Thank you.
Thank you, everybody.
Bye.